Good afternoon, everybody. My name is Mitch Woldt. I'm a nurse practitioner. I am with Stillwater Medical Group, and I'm actually out in the internal medicine group out in Hudson. And as Donna said, if you have questions, you can enter them into that chat function, and I will answer them as I go through my slides here. And so first off, I just want to let everybody know I've kind of different information throughout the PowerPoints. I know some patients have a little more information or knowledge about some of the medications or ways of lowering blood pressure. So I have different information, and I will touch base on a few different aspects. So again, if you have questions throughout, let me know. Otherwise, I am going to get started. So some of the main things that I will touch on are the new guidelines and what exactly the new guidelines mean, but also ways to help reduce blood pressure as well as medication and non-medication ways of lowering blood pressure. All right, so to start off with, last year in the fall of 2017, the American Heart Association and the American College of Cardiology set new thresholds for blood pressure. So the new guidelines state that normal blood pressure is anything under 120/80. And so this is not really any change. And then they also stated that elevated blood pressure is that top number being 120 to 129 and the bottom number being below 80. So again, there's no change with this new threshold. But what did change is that instead of having what used to be pre-hypertension and hypertension, they've now combined it to just having stages. So stage 1 hypertension is defined as that top number being 130 to 139, and that bottom number being between 80 and 89. This used to be what we considered the old name as pre-hypertension. And so then they've now had stage 2 hypertension, or what we considered that old being hypertension. So stage 2 is now defined as that top number being anything above 140 and that bottom number being below 90. So what exactly do these new numbers, these new guidelines mean? And before last year, what it meant is roughly about 32% of the American population would have been classified as having high blood pressure. And so now what it means is potentially somewhere around that 46% of Americans now will be classified as having high blood pressure. And so I get asked a lot, what was the purpose of making this change? And the goal really is meant to put focus on helping reduce cardiovascular risk, and hopefully by doing this, resulting in earlier interventions for patients as well as helping reduce their cardiovascular risk for the future. And so continuing on, a lot of times we call hypertension that silent killer because we can't always see the effects that it's having on our heart or our brain or our kidneys, or how it kind of combines even with other comorbidities like diabetes. And I found this next part kind of interesting, that roughly about every 12 minutes somebody unfortunately dies as a result of a complication due to high blood pressure. And again, that can be related to heart attacks, strokes, kidney issues. There's a lot that goes in with it. And just something that I always like to remind for everybody, that the systolic blood pressure that we call is that top number. And it's measuring the pressure against the arterial wall as the blood goes throughout your body. And that bottom number is the diastolic, and that's measuring the pressure for your heart as it's in that rest mode or that filling mode. Some people have questions about what exactly does the bottom number, top number mean, so a little information for you. And so other tips that I kind of wanted to have for people, because I get a lot of questions about, what really is the most appropriate way of checking blood pressure. And so I want to give you a little information of things that you can do so prior going into an office visit. And so one of the biggest things that we always tell people is to make sure you're resting prior to checking your blood pressure. A lot of people are always rushing to get to their office visit. They're running up the stairs, running down the hall. Make sure that you can sit for a good 5 minutes prior to getting your blood pressure checked. Also, another thing is sitting in a chair with your legs uncrossed and feet flat on the floor. This can make a big difference for people, especially if you can't reach the floor, or if your legs are crossed. It can definitely increase your blood pressure a little bit. One thing patients don't always think about is making sure that the blood pressure cuff is actually the appropriate size and is actually on your upper arm. I get a lot of patients that have questions about, well, what's the best place to have the blood pressure cuff? Upper arm, lower arm, wrist. And really the upper arm is the most ideal spot for checking blood pressure. And I get a lot of patients that come in and tell me, well, I had my blood pressure checked at the dentist office, and they put it on my arm or my wrist, and my blood pressure was either high or normal. The problem is when people will have either on their arm or their wrist, a lot of times they actually bend at their elbow to put their hand at their heart. What happens is that actually pinches off your vessels in your arm and can actually adjust your blood pressure either higher or lower than it really is. Another thing is when you're getting your blood pressure checked, it should be at heart level. And again, not bending at the elbow to be at your heart, but your whole arm, going from the shoulder should be at the heart level. And so a lot of times what I do is I have patients put their blood pressure cuff, we put the blood pressure cuff on, and I will hold their arm at the elbow, keeping it at the heart level. And it actually does make, a big difference for lowering blood pressure, but it's not just lowering it. That's more of the natural position for your blood pressure. Nothing's pinched off. So go ahead and ask your provider or the assistant to help keep your arm elevated as they're doing it. And if your blood pressure is high in the clinic, it should be repeated at least 1 or 2 more times. Typically, we don't just go off of one elevated blood pressure or high blood pressure. We will check it a few times. And if it was high and, unfortunately, if we forgot about it, just remind us to please check it again. And kind of going off what I was saying before, hypertension usually is not diagnosed just in one office visit or off of one blood pressure reading, unless it is very high. That's kind of the unusual circumstance. If it's really high, then there will be other issues that we would get into. But most of the time for general hypertension, we're not going to do it just off of one reading, off of one blood pressure. If the blood pressure, again, is elevated multiple visits, typically at least 2 to 3 office visits, and elevated, again, 2 to 3 times each office visit, then typically we would make that diagnosis of hypertension. An interesting thing is we're really finding out that home blood pressure monitoring is very useful and more accurate. People are under less stress. People can do it at home, at the same time of the day, doing their normal routine. And we are actually at Stillwater Medical Group doing kind of some research on having patients do blood pressure at home, and their machines are electronically able to send their information to us through our computer system. And we're having really good success because we are seeing lower blood pressures, and patients are happier that they can check their blood pressures at home without having to come into the office and worry about that white coat syndrome. Another very important aspect is making sure that the machine is accurate, and again, that the cuff is the correct cuff for you. And so one thing, a lot of offices, we will have patients bring in their machines, bring in their cuffs to make sure that these are the best for you. And a lot of times we tell people you want to do this about every year to make sure that your machine is calibrated and giving you the correct numbers. And again, this is typically a free service that many primary care offices will do. So when do we treat blood pressure? So with the new guidelines, and it's pretty consistent with the old guidelines, that lifestyle modifications really are still the initial treatment for either elevated blood pressure or even that stage 1 blood pressure. And basically any of that blood pressure that hasn't reached that top number being above 40, that bottom number being above 90, we still recommend doing lifestyle modifications. And so one of the interesting aspects that a lot of people haven't heard about is we really look at this, we call it your cardiovascular risk score. And this is something that looks at multiple aspects for patients, combines age, weight, cholesterol, whether they have diabetes, whether you're a smoker, and it gives us a percentage of the chance of having any type of cardiovascular issues within the next 10 years. And our goal is to have everybody be under that 10%. And so this is something a lot of patients will ask, well, how do I know when to potentially go on blood pressure medication? So if you have multiple issues, again, like diabetes or high cholesterol, and now you start having elevated blood pressure, your provider can use this cardiovascular risk score to help kind of identify some of the aspects of ways to help understand, well, your risk is going up and these are the things that we can change. And by doing that, then sometimes we find out that we do need to start blood pressure medication. So it is a very nice tool, and it's something that can be printed out so patients can look at it. And I do this all the time of printing it out so I can really show patients by lowering your blood pressure, you would decrease your chance of having a heart attack or stroke by a certain percentage. So it's very helpful. So how can we lower blood pressure? Again, lifestyle modifications are still the number one things that we try to do. Again, most important, diet and exercise. So one thing we talk about for diet is sodium intake. And a lot of data has been out there of trying to find out, well, what really is kind of that perfect number for sodium intake. And there is a lot of data out there. And so most recently, what we're finding is anywhere between 2,300 to 2,400 milligrams daily is kind of the most ideal for lowering blood pressure. And it is kind of amazing when you start looking at all of the things that you take in, anything that you drink, anything that you eat. There's a lot of sodium out there. And so one of the things I tell people about with sodium is, is especially for cooking, don't cook with salt and have salt on the table. Just do one or the other. That sometimes can make a pretty big difference. Exercise. So normally what we tell everybody is trying to exercise at least 30 to 60 minutes at least 3 days a week. And sometimes that's not always possible. And some studies are actually starting to show now that really reaching that 150 minutes per week is ideal. But what we're really finding is actually some of the benefits, instead of doing it that 3 to 5 days a week, we are actually kind of finding that for many patients doing that 2 days a week. So those people that don't really exercise as much during the week, but do a lot of exercise on the weekends, the mountain bikings or running, actually is still showing a pretty good benefit for helping reduce blood pressure and future cardiovascular risks. And so other, again, exercises that you're able to do. So walking, running, biking, swimming. I even put shoveling in there since living in Minnesota. That actually is a really good workout. And I get a lot of patients ask, well, what really is kind of the goal? How do you know that you're getting a good workout? And so really our goal is getting your heart rate elevated enough that you get a good, sweat and that you're breathing harder. And by breathing harder, typically we tell people you shouldn't be able to have a full conversation with somebody without feeling like you've got to take another breath. If you're able to sit and have a conversation talking, you're probably not working hard enough. It should be where you can only do a couple of words and you've got to take a breath. Many times we tell people a heart rate goal above 100 is also ideal. Now, granted, some patients are not able to do this, either joint-wise, physically, or even patients that are on medications like beta blockers. They're probably not going to be able to get their heart rates up above 100. and that's okay. We just have to work with patients on specific tasks and goals for them. One thing I always tell people, I get a lot of patients say, "Oh, I like to go, do biking," but unfortunately, if you're sitting on the bike reading a magazine, it's probably not quite doing the trick for you. Alcohol consumption and caffeine consumption is one thing that we touch base on a lot as well. Typically with alcohol, no more than 1 to 2 4 to 8 ounce drinks per day, and that's typically 1 4-ounce glass of wine or 2 8-ounce cans of beer. Reducing stress, this is a really big one too, and there's many ways of doing that. There's yoga, there's meditation, reading. I tell patients whatever works for you to help reduce your stress, that's ideal. And also getting adequate amounts of sleep. Interrupted sleep, whether it's sleep apnea or just feeling so tired that you have to sleep more or not getting well rested, can greatly increase blood pressure. And so I tell patients, talk to your primary provider. If you know that you snore or if you wake up in the night and you feel like you're gasping, these are signs of sleep apnea. And they can, one, can definitely raise your blood pressure, but two, can also lead to other issues. And so we do find for a lot of patients that if we actually end up treating their sleep apnea appropriately, a lot of times their blood pressures come down. And I have had patients, by treating their sleep apnea, have actually been able to get off of blood pressure medications. Staying hydrated, drinking at least 64 ounces of anything non-caffeinated, non-alcoholic per day. Be surprised actually how many people don't drink enough adequate fluids, and that can actually affect your blood pressure either higher or lower. Other factors, I tell everybody one of the most important things is if you're a smoker, please stop. It's enough said for a lot of patients. I know it's not the easiest thing, but there are so many ways now that can help with quit smoking between medications, even talking to people. Smoking really can affect blood vessels and arteries. That leads to a lot of other issues. For patients, if they have high cholesterol, being on a statin medication, if indicated. Not everybody who has high blood pressure or high cholesterol needs to be on a cholesterol medication. So this is, again, something to talk with your provider about. Diabetes and blood pressure a lot of times really kind of go hand in hand for patients, getting them both under control. And depending on age and risk factors, having a hemoglobin A1C under 7 or 8, again, depending on age, can really actually help improve future potential complications with hypertension. Again, depending on risk factors, family history, patient's history, potentially even being on an aspirin. And healthy weight. I tell people it's amazing what a few pounds can do. I know one orthopedic surgeon that said for every 2 pounds of weight that we have, it's an extra pound on your joints. So even a few pounds is amazing what it can do for your joints as well. So I'm going to kind of get into the more medication-based aspect now. And there's a lot of medications out there, so I really just kind of want to touch base on some of the most common medications, medications that I get the most questions about from patients. And so one thing is that the new guidelines do not recommend beta blockers as being first-line treatments. And so beta blockers, a couple of medications are atenolol, metoprolol. These are medications that actually kind of help slow down the heart rate. And so these are not indicated for just blood pressure management anymore. So I tell a lot of patients, if you're taking medications like atenolol, metoprolol, or any type of beta blocker, and only taking that one for blood pressure, talk to your primary provider about that. They may want to actually transition you to a different medication that has better long-term effects for blood pressure. And one thing I always tell patients too is treatment options really are tailored per patient. We have protocols, we have lines that we try to follow, but there's no set for, one patient has to be on this medication and only this medication. It really is tailored to our patients, to what we want that long-term goal to be or potential complications to look at for the future. So some of the first-line medications that we look at are medications that are called ACE inhibitors or ARBs, calcium channel blockers, and lastly then diuretic or thiazide-like diuretic, or a lot of times we just call it a water pill. So who gets which medication? Again, we really base this off of each patient. So sometimes for patients, excuse me, if they tend to get a little bit of leg swelling, whether it's walking, being outside and it's hot, so sometimes then for patients we'll do those diuretics. For patients who may have diabetes or other what we call metabolic syndrome or other kidney issues, a lot of times then we'll go with an ACE inhibitor or an ARB, as they have good blood pressure management but actually can help protect the kidneys a little bit. And for patients who need heart rate control, somebody maybe who has AFib along with high blood pressure, then we look at more of the calcium channel blockers like the amlodipine, the Norvasc, because they help lower blood pressure but also have heart rate control properties to them. I do get a lot of patients that ask questions, well, what about something like Lasix? A lot of people have heard about Lasix. Lasix really should not be used for blood pressure management. That is more, it's a diuretic, so it pulls fluid off, but really is not one for blood pressure. So if you're taking Lasix just for blood pressure, again, I would talk to your primary provider. There are other medications that will have better long-term effects than just doing Lasix. So for medication-wise, typically we do start out, sorry, hold on one here. I just had somebody had a question here, and I need to figure out how to get in here. Sorry, give me 1 second. Sorry, it popped up here, but then I don't know where it went. Okay, so sorry. Somebody had a question. So the question is, lisinopril is used for patients that have metabolic syndrome. What is metabolic syndrome and how does lisinopril affect it? So metabolic syndrome is actually, it's a combination of many things. It's kind of a general term. So metabolic syndrome is for somebody who may have starting to have high blood pressure, starting to have some kidney issues, also somebody who has maybe pre-diabetic, not quite diabetic, and a couple other things in there. So it's actually a combination of diseases kind of happening all at once. And what happens with lisinopril is by helping lower blood pressure, so that's one thing that it's doing, is it's lowering blood pressure, but also what it's doing is lisinopril, ACE inhibitors or ARBs is another name for medications. What they do is by helping reduce blood pressure, it actually increases blood flow to the kidneys. And by increasing blood flow to the kidneys, it's protecting your kidneys, trying to help prevent somebody from potentially having to go on dialysis. A lot of people have heard of dialysis. And so what happens, it's kind of a multifactorial effect. By being on lisinopril, it helps with the blood pressure, which thus then helps protect the kidneys, help the kidneys function a little bit better. So it's not just that lisinopril prevents metabolic syndrome. It's by helping one thing, you help another, kind of help another. Hopefully that kind of answers the question. So back to the slide. So a lot of times we start out with one medication, and we start out at a low dose and slowly titrate up. A lot of times, patients can be frustrated that they have to come back a lot with this, but it really is the best case, so we don't have somebody get a low blood pressure and start getting dizzy or passing out. Sometimes for patients, one medication is enough. Many times, though, however, patients need higher doses of that medication or additional medications. And a lot of times, as we age, more issues start happening, majority of patients really end up needing to be on 3 to 4 medications for adequate blood pressure control. And I tell patients this not to say that anything's wrong. I tell people that just knowing what for the future, that over time you're probably going to end up being on more medications, and that doesn't mean anything's wrong. That's just kind of the natural progression with high blood pressure. And again, so the goal for most patients is to be that your blood pressure to be under 140/90. However, depending on previous heart history, medical conditions, this goal might be lowered. And I tell patients that goal, especially if you've had somebody who's had a heart attack, that numbers, we're going to want that lower. Part of it, too, is age. I tell patients, if I'm seeing somebody who's 20, 25 years old, I'm going to want that blood pressure lower than that 140/90. And kind of going back to us talking about before about that cardiovascular risk, it's really, we're looking at, a lot of times our numbers, we're looking at that 10 years. What can we do to help prevent issues for 10 years? So if you're talking about somebody who's younger, well, we've got a long ways to go. We're going to really want to lower that risk for that 10-year risk for a long period of time. And then not all patients are the same. Talk to your provider about what your goal is. Again, that 140/90 might not be right for you. It might be lower. It might even be higher. Can blood pressure be too low? Yes, it definitely can. Feeling dizzy, lightheaded, unbalanced can all be symptoms of low blood pressure. Some medications, this is more common, such as metoprolol. What metoprolol does is it actually lowers the heart rate. And by lowering your heart rate, for people who stand up too quickly, your heart can't pump faster to get that adequate blood flow to your brain, and people get dizzy. So what can help with that? Sitting at the edge of the bed prior to standing, or standing slowly when getting out of a chair. A lot of times for patients, once they know that this is a natural thing that can happen with this blood pressure medication, they learn to adjust to it. But again, if it's getting to the point where it is affecting your daily living, let your provider know. I tell patients we can't help if we don't know. Don't live with symptoms if it's affecting you. Let us know. Let us try to help. One interesting thing I do tell people is we try not to let that bottom number, that diastolic number, get below 60. If that number gets below 60, this can increase the risk of kidney or heart issues because it actually means that there's not adequate perfusion. Again, it's not always, that number. I don't want every patients to get worried if it's every once in a while below 60, but we do kind of have numbers that we look at to try and help make sure it doesn't get below as well. So kind of wrapping up here. So again, if anybody has questions, please let me know. But otherwise, in conclusion, the new guidelines really are meant to help increase awareness of what exactly is hypertension and what are ways that we can help prevent further complications for patients. The goal really is with more awareness, hopefully comes more accountability for patients and providers. And then by doing this, we get a decrease in hypertension rates as well as hypertension-related diseases. I've read different things that say, well, this may increase a burden for primary providers. More patients are going to be diagnosed coming in. Well, I say that's our job. This is our job, is to educate patients, to educate what are the options out there. And then lastly, there are many ways to help lower blood pressure. It's not just medications. Diet, exercise, again, are still the mainstay for trying to help lower blood pressure. And again, talk to your provider about your goals. Not everybody is going to have the same goals. Talk to us. Let us know. Let's make a plan together. And again, lastly, I just tell all my patients with this, if there's something going on, talk to us. If we don't know what's going on, we don't know how to help you. And that actually concludes my slides and information. Again, if there's any questions, you can type in that chat setting. Otherwise, I am going to hand it over to Donna.
Thanks, Mitch. That was really helpful. We're just going to hang on for another minute to see if we have questions for Mitch to answer. And like we said, we recorded it, so I will send out a link to the recording later this week. And if you have any suggestions for other topics, you can let me know that too when I send the email out. Let's see, wait another minute, see if you've got any questions, and then we'll close out. Well, I don't know how fast you guys can type, but I'm not seeing any questions come through, so we are going to say goodbye for today, and thanks, everyone, for joining us.